Hello everyone, I'm Dr. Kanchan Prashant Sugandhi. I'm an assistant professor and a PhD scholar at College of Physiotherapy, Dayanand Sagar University, Bangalore, Karnataka. Today I'm presenting a scoping review which is on the topic of artificial intelligence enhanced communication for mechanically ventilated ICU patients. So communication in ICU is really important. It is happening between the healthcare professional, the ICU patients and their family members. It helps in planning and executing a high quality treatment towards the ICU patients. About the mechanical ventilation, it is crucial for the survival of the patients who are having critical care requirements. Patient may have a pulmonary disorder or a trauma which may take them to a requirement for a mechanical ventilation support. But this mechanical ventilation causes a communication barrier between the patients and the healthcare professionals. Because of this, the patient may face frustration, anger, or any other physical and psychological distresses, and they are not able to express their needs and thoughts because of the communication barrier led by the mechanical ventilation. In one study, we found that the ICU patients have different types of needs. Their needs are divided into basic needs, emotional needs, and cognitive needs. The basic needs are the ones where the patient is trying to communicate for his pain, for his needs, for his discomfort. The emotional needs are the ones where the patient is trying to communicate his emotional trauma or fear or anxiety levels. The cognitive needs are those where the patient is not able to make a decision participation when the rehabilitation is planned, or when the patient is not aware or oriented to the surroundings. Coming to the needs of study, in the previous studies we found that there are already existing solutions to enhance communication between the ICU patients and the healthcare professionals. Those communication tools are communication boards, writing tablets, sign languages, AAC, those are augmentative and alternative communication devices, and digital applications. These devices require training as well as they require a kind of integration to be done in the ICU setup. And for the mechanically ventilated patient, it is difficult for them to get oriented to those devices or to those communication tools. So the purpose of this study is to review what are the commonest things which are being currently used and what are the application going of all the communication tools, and how are they helping in improving the communication between the healthcare professionals and the ICU patients. Coming to the research question, so there are already existing and stabilized tools which are available to enhance the communication between mechanically ventilated ICU patients and the healthcare professionals. But are they standardized or are they really patient centered? So my question is, can this artificial intelligence, which is an emerging technology nowadays, can it facilitate a feasible communication pathway between the mechanically ventilated ICU patients and the healthcare professionals? Coming to the methodology, so for this review, we conducted an extensive literature search on different databases which were PubMed Central and Advanced, Google Scholar, Clarivate, Scopus, Sinhal, etc. The keywords which were used for the search included communication, intensive care unit, artificial respiration, communication barrier, mechanical ventilation, alternative and augmentative communication, speech recognition software, artificial intelligence, machine learning. The booleans which were used in between of these search terms were or and was used among the commonest searches. The inclusion criteria for the scoping review included the studies which involved adult patients, mechanically ventilated patients who had speaking difficulties. Then the patients must be cognitively intact, and the use of artificial intelligence as a communication strategy in ICUs. The exclusion criteria for this study were the studies which were discussing the communication between the patient and the family and the role of family in the rehabilitation, the effect of family support and the communication of the patient for the quality betterment life with the family. So in the identification process, through the different databases we found 1217 studies, and with the help of the cross references we found 14 more studies. So the total studies were 1231, out of which with the help of deduplication process we removed 1168 articles. The remaining articles, those were number 63, were taken for the screening process. Of these 63 articles, we excluded 28 articles on the basis of the abstract and the title screening. The further articles, that were 35 in number, were again screened for the full text. After the full text screening, we removed 12 articles, and the total articles which were included for the scoping review were 23. So the articles what we took were ranged between 2001 to 2024 year, and in the results we found that out of the 23 included articles, 13 were review studies which were systematic reviews, scoping reviews and meta-analysis, 5 were observational studies, 2 were case series, and we had one validation study, one feasibility study and one phenomenological hermeneutical study. This phenomenological hermeneutical study was mainly taken based on the experiences, live experiences of the patient and the interviews of the staff. In the overall results, we found that there are technological integration in ICU is accepted all over the world, and it is in the form of alternative and augmentative communication tools, eye tracking technology and digital applications like Speak for Myself, and one more application, VidaTalk. In most of the studies, we found that the use of artificial intelligence and the other tools have been focused on the diagnostic and the therapeutic management for the patients. The use of AACs or communication boards were done for the manual support towards the rehabilitation planning, but the use of AI was done in the format of natural language processing and the machine learning models by evaluating the electronic health records of the individual. There were less use of direct patient interaction using artificial intelligence software. So the current concerns which comes up with the result of the scoping review is that there are ongoing challenges in the nurse-patient communication, and there are barriers for the effective implementation of such tools and AI application in ICUs, and there are lack of high quality evidences and experimental studies which promises the high quality use of artificial intelligence in ICU settings. So as we discussed in the previous slide in the result, the ICU communication strategies found in our results were divided into 4 main categories, which were structured nurse-patient communication, which included sign languages and presumed interpretations, the AAC tool, that is the alternative and augmentative tools, the eye tracking devices which helped in expressing the pain levels of the patient, and the basic communication applications like Speak for Myself, etc. So the discussion of the scoping review comes under 3 points. First is, we found that there are several studies including systematic reviews which have discussed about different communication strategies, but those strategies are subjective to the person who is using it. Also, they are training dependent. That means the patient and the ICU staff both have to be trained for such communication strategies, and they are economically controlled because the integration of such communication strategies such as eye tracking technology or AAC communication boards, etc., needs to be integrated into the ICU settings. Coming to the second point of discussion, so as we got to know, the artificial intelligence is already being used in different ICU settings in different parts of the world. For the diagnosis purpose, the artificial intelligence is used as a natural language processing and ML models for of different radiological images interpretation. And for the therapeutic purpose, they are using the electronic health records of the individuals, of the patients admitted to the ICU, and based on their records and the vital monitoring, they are planning the management using the artificial intelligence. However, coming to the third point of the discussion, we found that there are different tools available for the communication, but there is a lack of standardized outcome measure to find out whether they are actually working for the patient or not. And there is a lack of randomized controlled trials for the usage of artificial intelligence in ICU settings. There are very less multicentric studies, and there is limited long-term follow-up data on the usage of artificial intelligence in ICU settings. So all these points really questions the reliability of the evidence of artificial intelligence usage in the ICU. Coming to the conclusion of this scoping review. So as I said, artificial intelligence, which is already being used in ICU, has a lot more potential to transform the ICU experience for number of patients annually and all over the world. It can reduce their suffering. It can promise them higher efficiency in the treatment plans and treatment approaches. It can enhance their communication. It can provide them long-term improvements. It can lower down the mortality predictors, and it can also be cost efficient. Also, in this scoping review, we understood that there is a trend which is shifting from the established modes of communication towards the emerging modes of communication for mechanically ventilated ICU patients. So we conclude that artificial intelligence can prove an helpful hand to the healthcare professionals and to the medical system for providing individualized and patient-centered care for the mechanically ventilated ICU patients. These are the references for my study. With this, I would like to put a message that artificial intelligence can be a promising tool in enhancing communication for the mechanically ventilated ICU patients. But of course, the need of high quality evidences and multicentric studies remains a priority. Thank you so much.